So this lecture today is going to examine some of the treatment options that exist for the management of patients with Alzheimer's disease. Learning objectives. Fortunately, there's not that many because there's not that many drugs that can be used to treat these patients. So the first group of drugs we need to look at are the cholinesterase inhibitors. Patients with Alzheimer's disease typically have reduced acetylcholine being released into the synapse, leading to impaired cortical cholinergic function. Donepezil and rivastigmine reversibly and non-competitively inhibit central active acetylcholinesterase, the enzyme responsible for the hydrolysis or the degradation of acetylcholine. This results in an increased concentration of acetylcholine available for synaptic transmission within the central nervous system. Galantamine is a centrally acting cholinesterase inhibitor, both competitive and reversible. It elevates acetylcholine in the cerebral cortex by slowing the degradation of acetylcholine, modulating nicotinic acetylcholine receptor activity to increase acetylcholine release from surviving presynaptic nerve terminals. It may also increase glutamate and serotonin levels. These drugs are all centrally acting, basically allowing them to cross the blood-brain barrier. The side effects of these drugs include nausea and vomiting. GI symptoms are the most common, especially with prolonged use of donepezil. GI symptoms are also quite common with galantamine. Oral rivastigmine should be given with food and titrated more slowly than other drugs due to increased risk of nausea, vomiting, anorexia, and headaches. And of course, to help with the GI symptoms, these drugs should be taken more or less with food. Glutamate, the primary excitatory amino acid within the CNS, might contribute to the pathogenesis of Alzheimer's disease by overstimulating various glutamate receptors, leading to excitotoxicity and neural cell death. Memetamine is a non-competitive antagonist of the NMDA-type glutamate receptors, located ubiquitously throughout the brain. Under normal physiologic conditions, the non-stimulated NMDA receptor ion channel is typically blocked by magnesium ions, which are displaced after the agonist-induced depolarization. Pathologic or excess receptor activation, as postulated to occur during Alzheimer's disease, prevents magnesium from entering and blocking the channel, which results in chronically open state and excess calcium influx. Memantine binds to the magnesium site, but with a longer dwell time, and thus functions as an effective receptor blocker only under conditions of excessive stimulation. Memantine does not typically affect normal neural transmission. There is little, if any, evidence that patients with milder Alzheimer's disease even benefit from memantine. There may be some benefit in those patients with moderate Alzheimer's disease, however. Memantine, in combination with a cholinesterase inhibitor, in patients with advanced disease might work very well. Memantine has also shown to have some evidence of efficacy in patients with vascular dementia. Memantine may also appear to have fewer side effects than the cholinergic drugs. Dizziness is the most common side effect with this particular drug. So with frontotemporal dementia, there's a few drug classes that we can talk about. The neurochemical basis for FTD remains to be fully elucidated, and the number of neurotransmitter systems might be involved. There's behavioral symptoms that can vary from patient to patient. Patients with FTD typically are susceptible to adverse effects of medications and include paradoxical behavioral reactions, extrapyramidal side effects, confusion, as well as sedation. Typically, we start these patients on the lowest available dose of these medications and slowly upward increase the titration amount, frequently looking at side effects and monitoring patients as needed. Because it's common to see medications make behaviors worse, slow movement and reaction times, and cause a deterioration in cognition, it's reasonable to continuously reevaluate the justification of these medications in each individual patient. SSRIs have been reported to decrease disinhibition, anxiety, as well as impulsivity and repetitive behaviors. They've also been demonstrated to work in eating disorders, as we've talked about in a previous case. Atypical antipsychotic medications, which we'll examine later in this CNS block, including methylphenidate, offer some utility. Memantine typically is not recommended for these patients with FTD. Although the initial trials were small, it didn't demonstrate that memantine improved any type of behavioral symptoms in patients with FTD. So that's basically it for this particular section. Unfortunately, there's not that many drugs available for the treatment of Alzheimer's disease. Hopefully newer ones will be coming through the pipeline, and we can start treating these patients a lot better than what we've been doing. Thank you. If you have any questions, please email.